around that. And I am going to write right in the middle of those margins, in big enough that I won't miss it. I'm going to put assign only when doctor hasn't been able to arrive at related diagnosis, and you can abbreviate that as DX, but states abnormal finding is significant. So based on that definition, do you think you're going to be coding a lot of abnormal findings in a hospital? I doubt it. Are you in the doctor's office? Yeah, totally different set of circumstances. All right. Only use this when the doctor has not been able to arrive at a related diagnosis, but he indicates it in some way that the abnormal finding is considered to be clinically significant. All right, now this differs from coding practices in the outpatient setting when coding encounters for diagnostic tests that have been interpreted by a physician. So make sure you put that down, right down the middle of that page. In outpatient, do code it when listed, because that may be the only thing you're seeing that patient for today. For instance, if I go to my general practitioner and he runs a series of tests and one of the tests comes back abnormal, maybe it's the thyroid that comes back abnormal. At that point, he might want to refer me to an endocrinologist. Well, what's he referring me for? He doesn't know what's wrong with me. All he knows is I've had an abnormal thyroid test. All right, take a look at the next paragraph, though, on page 27. The coder should never assign a code on the basis of an abnormal finding alone. To make a diagnosis on the basis of a single lab value or abnormal diagnostic finding is risky and carries the possibility of error. Have you ever had an abnormal lab test yourself, and they repeated it and everything was fine? Yes. Do you, just because you've got a blood sugar that's high one day because you ate an ice cream cone on the way to the doctor's office, do you want somebody to diagnose you as diabetic because of that? No. So you have to be very, very precautious. A value reported as either low or higher than the normal does not necessarily indicate a disorder. Many factors influence the values: the collection device, the method used for transportation, the calibration of the machine, the condition of the patient. A patient who's dehydrated may show an elevated hemoglobin due to increased viscosity of the blood. So when the findings are outside a normal range, and the physician has ordered other tests or has prescribed treatment without documenting an associated diagnosis, it is definitely appropriate to ask the physician whether or not something should be added. Now again, notice beside that you have that exclamation point in that triangle. That's telling you that that's a tricky area and something you really need to watch out for. Example 1, a patient with a low potassium. Well, you can look at the chart and you can see they had a low potassium. You can also see that they got either an IV potassium or they got oral potassium. Well, gosh, you don't have to be too smart to figure that one out, do you? Well, at that point, the doctor never mentioned it, so what do? Well, we should bring it to his attention if there is no related diagnosis, because it may need to be indicated that there was a low potassium level. Example 2, you've got a hematocrit of 28%. Even though it's asymptomatic and not treated, was evaluated with serial, meaning multiple hematocrits. Because the finding is outside the range of normal values and has been further evaluated, the physician should be asked whether an associated diagnosis should be documented. All right, if you don't document it and you've done multiple tests, do you have any validation as to why you did those multiple tests? If you're an insurance auditor, are you going to question why the patient had 3 hematocrits? Yeah. So remember, the codes have got to tell the story. Okay, page 28, admitting diagnosis. Now, the admitting diagnosis is what the patient comes in with. it is not necessarily the same thing as the discharge diagnosis, is it? Because I may come in for one thing and leave having found it something totally and absolutely different. All right. We do know that for some payers and for the process of utilization review in a hospital, you will have to look at the admitting diagnosis. Now, utilization review, or UR, is that practice we have that helps us determine how long the patient is going to stay in the hospital, and we know that up front. Now, you heard me talk about the old way of utilization review a couple of weeks ago when we talked about Medicare patients who are going to be there for 12, 18, 30. All right. Now we don't do that. Now we use some statistical information, and we know pretty much how long a patient with a certain diagnosis is going to be in the hospital, don't we, based on their age and whether there's other things going on with it. All right, so if I am the utilization review coordinator and I look at the chart and I see that this patient is here for pneumonia, maybe pneumonia in that age population normally stays for 3 days. Okay, it's fine. I won't even probably look at that chart again for 3 days. But about the 4th day, I'm coming back, or the 2nd day, really, to see if it's ready for that patient to go home on the 3rd day. Well, if the doctor hasn't documented anything else, then it's probably time for that patient to go home. But if the doctor has documented some other problems to go along with it, is that going to possibly change the length of time that we think is appropriate for this patient to stay? So now, instead of doing utilization review after the fact, or after they've stayed 10 or 12 days, we try to stay on top of it. And we try to work with the physician and let's help get this patient out. Or if they're not ready to go, let's make sure they're getting the care that they're needing. Or if they are ready to go, let's make sure if it's nursing home care they need, let's get that. If it's home health care, they get that. We just try to be a lot more proactive about it. The inpatient admitting diagnosis may be reported as one of the following: a significant finding, such as a sign or a symptom that represents patient distress, or an abnormal finding on an outpatient exam. Could my admitting diagnosis be abdominal pain? Yeah, but that doesn't tell you a whole lot, does it? Could it be throat pain? Could it be leg pain? All of those things. A possible diagnosis based on significant findings. I've had in the doctor's office abnormal thyroid tests. Could I have a possible diagnosis of thyroid cancer? I'm stretching there, but it's possible. A diagnosis established on an ambulatory care basis or doing a previous hospital admission. All right, I was here 2 months ago, and you found that I had cancer of the colon. Well, now I'm coming back. What are you expecting my admitting diagnosis to be now? Probably the same, but does it necessarily mean it's going to be the same when I leave? No. Injuries, poisoning, things of that nature. If the admitting diagnosis is reported, the code should indicate the diagnosis provided by the physician at the time of admission. Let me just share with you probably the funniest admitting diagnosis I ever saw. And you wouldn't do it now, or I hope they don't do it now, because it was years and years ago. And we all wanted